I would say at this time there is an unclear role for PD-L1 testing within patients who have gotten the combination of a TKI and an immune checkpoint inhibitor. Certainly, we do have evidence that PD-L1 staining may be relevant for basically IO-IO combinations, and maybe even for Atezo-Bev. However, based off of what we've seen with Axitinib Pembro and based off what we've seen with Lenvatinib Pembro, it's a little bit less clear whether or not PD-L1 staining is able to predict responses.
One of the interesting findings from the Atezo-Bev trial was the PD-L1 status and whether that would predict or enrich a patient population that would do better. And it appears from that trial that indeed it does. We have looked at PD-L1 status in other trials, and PD-L1 status does enrich the patient population, meaning if you do have that, you do better or have a higher chance of doing better when it comes to efficacy endpoints. The problem has been that if you were PD-L1 negative with many agents, it didn't negate the benefit over sunitinib as the comparator. As we move forward, whether or not PD-L1 status will be a differentiator enough to help one select agents is unclear in kidney cancer. Certainly, there is some experience in other cancers, such as lung cancer, in it being a differentiator. So I think it's too early yet to say whether or not PD-L1 status. At the present, I would not recommend routine testing or stratification of agents based upon PD-L1 status outside of a trial setting.